Uterine septum is associated with recurrent pregnancy loss, infertility, and poor ART outcome. Here we have a 25-year lady with history of 3 previous miscarriages, around 7 to 8 weeks of pregnancy who came for fertility evaluation. History has no specific complaints, her periods are regular and there are no previous surgeries. Ultrasound shows a broad fundus and 3D transvaginal ultrasonography shows a subseptate uterus. Plan of surgery is hysteroscopic septal resection and diagnostic laparoscopy. We usually prefer early proliferative phase between day 6 to day 10 of the cycle because the endometrium is thin and visualization is better. Pre-medication with antibiotics and sometimes misoprostol is given to allow vaginal dilation. An informed consent is taken, including risks for perforation and adhesion formation. A general anesthesia is given, patient is placed in lithotomy position, and usually the procedure starts with laparoscopy to confirm a broad fundus and presence of septate uterus and also to rule out any unforeseen bicornuate uterus or unicornuate uterus which were not previously diagnosed. For septal resection, we prefer a 22 French bipolar resectoscope. This specially is useful when there is a broad fundus. Normal saline is the distension medium chosen, and the bipolar electricity is used to resect the septum. Using normal saline and Histromat for distension purpose, intrauterine pressure of around 80 to 100 millimeters of mercury is maintained using a flow rate of 150 to 250 ml per minute. Fluid balance is maintained meticulously. Initially, the anatomy is located, the location of external os, internal os, and both the tubal ostia are identified. Resection starts at the apex of the septum in the midline in the avascular planes, and using bipolar resectoscope, resection proceeds stepwise in an upward direction under direct visualization. Resection has to stop when both the tubal ostia are clearly visible at equal depths and the lateral wall contour is symmetric. Avoid going too deep where the myometrium may get thinned out to prevent perforation of the uterus. We can use either a transabdominal ultrasound or laparoscopy guidance to guide us about the depth of resection. Postoperatively, a short course of estrogen is given to prevent adhesion formation, and conception is usually advised to be avoided for at least 3 cycles later.